Good morning, all. Welcome to the seminar of Basics of Invasive Mechanical Ventilation in Children. I am Dr. Avijit, one of the consultant in pediatric intensive care in DMICC Jaipur. So let's begin that. So basically, objectives of this class is today is the how the ventilation begins, what are the aims of mechanical ventilation, physiology of ventilatory support, initiation of ventilation, ventilator graphics, different maneuvers, commonly used maneuvers we used in them, as well as the winning process. This is the man whose name is Andrea Vesalius from Belgium. In 1600th century, first coined the term how a patient was ventilated. He's an anatomic professor at the age of 23 years. He said that if you put a tube inside the trachea and we just inflate the lung, blow into the this, then only the lung rises. That's the first concept of ventilation started. After a long gap in 1800th century, first negative pressure ventilation or iron lung ventilation started. The modern day positive pressure ventilation started at the 1950 after a polio endemic at the Copenhagen. So at that time, the positive pressure ventilation was a new thing and also a new adventure for the people. Next important thing is that indications of mechanical ventilations, which generally we ventilate for few common causes, either due to apnea, respiratory failure, or ARDS or respiratory distress syndrome, neuromuscular conditions like muscular dystrophy, asphyxia child, commonly brain trauma child, as well as congenital heart disease and other conditions where we need a good gas exchange. Let's see that what are the physiological goals. Physiological goals of any mechanical ventilation is removal of carbon dioxide and maintenance of oxygenation. Along with that, we have to understand ventilation can cause a harm. So we have to consider about ventilation-induced lung injury. There are some specific clinical objective of mechanical ventilations, like other than this gas exchange, we sometimes use to reduce the intracranial pressure, to stabilize the cardiac output, as well as to stabilize the chest. Before we understand the mechanical ventilation physiology, we should understand the basic physics of mechanical ventilation. There are three important terms. One is called pressure, one is called flow, another is the volume. So these are three things that are very important. Three important terms are very important to understand the mechanical ventilation. What is pressure? Pressure is nothing but the force per unit area. What is the flow? Flow is volume, change of volume in change of time. Whereas volume is volume flow times time. So basically, volume depends on the flow. If you increase the flow, volume will increase. We'll understand how they are interrelated in next slides. Another two important terms we use for any type of elastic properties of. So here, elastic property of the lungs and chest wall, we use compliance as well as elastance. What is compliance? Change of volume by change of pressure. So how much volume is changing with so equal amount of change of pressure? That's the called compliance. And the inverse of compliance is called volume, elastance. What is resistance? Resistance is change of pressure in per unit of flow changes. So basically, whenever the resistance increases, whenever the pressure is required more, or the flow is decreasing, then the resistance is more into the circuit. Next, the most important equation we use for mechanical ventilation, that's called respiratory equation of ventilation. Equation of motion. We can see this is a model of single tube and single elastic property. We think about a single elastic lung. So whenever a gas flow is happening, because of the transthoracic, the pressure gradient, gas flow is coming from the mouth to the alveolus. There are various pressure we should understand: transairway pressure, transthoracic pressure, transrespiratory pressure. Basically, all this pressure is required to overcome the compliance of the lungs and chest wall, as lungs chest wall, as well as the resistance of the chest wall. So if we equate the motion, the pressure required for ventilation and pressure required for the muscles, we'll say that elastance into volume plus resistance into flow. So basically, in a certain point, if the elastance and resistance is constant, So there is change of volume, pressure, as well as the flow. So there are three variables: flow, volume, as well as the pressure. Now we know that spontaneous ventilation is a negative pressure ventilation, whereas we are going to discuss about the positive pressure ventilation. Basic difference between negative pressure ventilation and positive pressure ventilation is that there is a negative pressure is created inside the alveoli during spontaneous ventilation. That's why air is moving from outside to inside the alveoli. And expansion is a positive process. As a passive process, so air is coming out. So we can see that negative direction, always the airflow will be the negative deflection. That's the convention. Whereas the positive pressure ventilation, as we see that there is a positive flow of air, and also you can see that there is a gradual positive of the alveoli, and after a certain extent, the positivity goes maximum and the pleural pressure also increases. Then the expansion is happening because of the recoil of the lungs, and there is negative deflection of the airflow. Next important thing is that we should understand the basic parts of ventilator. This is the screen of the ventilator or monitor. This is the compression or some other parts are there. At the back side, we can see the two tubes. One is the oxygen tube and one is the air tube. So air oxygen mixture is required, and this is called filter, which should be changed to air filter, and these are the power cord. And also important thing is that we should understand that a flow sensor for this our Mackay ventilator. There are various ventilators are there. We are using here as an example of Mackay ventilator. We can see there's a flow sensor. This is very important. It should work for working of a ventilator. Before we start the ventilator, we should do the pre-use check. It should be passed, otherwise don't connect to the ventilator. Now, whenever we use a Mackay ventilator as an example, we always see there are two things. One is adult mode, whether you start the adult mode or the infant mode. Generally, in infant mode, we start below 20 kilo, in adult mode above 20 kilo. So whenever we start the ventilator, there are various knobs are there. These are the monitor knobs. From these knobs, rotating the knobs, we can change all the values. In pressure control ventilation, what we'll discuss later, we generally control the pressure. Otherwise, we control the respiratory rate. We set the PREP, set the FiO2, set the TI, and I ratio is automatically set. Next, in volume control ventilation, we generally set the tidal volume, and whenever we changing the tidal volume, automatically the minute volume as well as the flow will change. Increase the tidal volume, flow will increase, and increase the tidal volume, minute volume also will increase. Other parameters are almost the same. We always keep the I ratio 1:2 in volume control ventilation also. So whenever we switch on and started the ventilator, we see some parameters. These parameters are set parameters, whereas these parameters are measured parameters. We can see the P peak, P mean, P double E, P peak, actual measured P, actual respiratory rate. That means patient's ventilation rate as well as the machine rate. And also we can see the FiO2, how much we are giving, as well as the minute volume. There are other parameters we can see, expiratory tidal volume also. So if you want to know the other parameters, we can do that additional values also. Next, there are important things, curves are there. These are called scalar curves. These are very important. These are ECG of ventilator. This is a pressure control ventilation. You can see that this is the pressure scalar. This is the flow scalar. This is the volume scalar. Depending on the flow scalar and pressure scalar as well as the volume scalar, we understand what type of mechanical ventilation is going on. We'll discuss later. And these are called loops. This is called volume pressure loops or pressure volume loops. And this is called flow volume loops. How will you start the ventilator? The next question will come, how will you start the ventilator? Before you start the ventilator, we should understand a few important points. Before we start, we should understand whether we need an invasive or non-invasive ventilation. We need a full support or partial support. What type of mode we want to start, which type of ventilator we start, because there are advanced mode of ventilation also is there. Next, we have to set the key ventilator settings, but most important thing that we always forget how to set appropriate alarm on mechanical ventilator, as well as setting the backup values whenever child is taking spontaneous breathing on spontaneous mode of ventilation. So we can see here, the initial parameters, what we said, the mode, we'll discuss in details. It could be spontaneous mode, that is pressure support and CPAP, and also it could be the controlled mechanical ventilation or SIMV. Then we set fractional inspiratory oxygen, then peak inspiratory pressure, then positive and expiratory pressure. Peak expiratory and expiratory tidal volume are set as per the target tidal volume, 6 to 8 mm. Whenever we set the pressure, we see that what is the expiratory tidal volume. When we set the volume, we then generally consider the positive inspiratory pressure should not go very high, less than 28 at least. Normally, we set positive end expiratory pressure that maintains the functional residual capacity at the level of 3 to 5. Respiratory rate, though there is a standard criteria, but we generally use it as per the patient's demand or patient's disease condition. Same time, inspire time also set as per the disease condition. Poor compliant lung, inspire time will be less. Good compliant lung, inspire time will be more. So we have to finish the inspire. So whenever we set the inspire time and expire I ratio or inspiratory expiratory ratio will be set automatically. Normally we kept 1:2 or 3. At the same time, we have to set the trigger. Normal common trigger in spontaneous mode ventilation, we use flow trigger, and pressure trigger is used for other purpose whenever the flow is leaking or gas is leaking from the circuit. Next, we dissect a breath. We want to know how a breath happens. This volume control ventilation, we generally, all ventilation happens because of the flow, gas flow. We can see there is a flow curve. From this flow curve, this part is called inspiration, inspiratory time. Then this one is the inspiratory pause. Total is called inspiratory time. Then there is a expression is the negative deflection in positive pressure ventilation. And then it touches the baseline. After that, there is a pause of flow. There is no flow. So this is expiratory no pause zone. This is inspiratory no pause zone. Normally, we measure P plat or plateau pressure at this level. Whenever we need a breath, we need somebody should initiate the breath, that's called trigger, and somebody control the breath, how much we want to go, and then somebody cycle it or stop it from inspiration to expiration and expiration to inspiration, as well as we need some baseline pressure. Before we do that, we have to understand what is spontaneous breath, what is mandatory breath. Normally, whenever patient is paralyzed and sedated, all breaths are mandatory. Whenever patient is not sedated but patient is awake to some extent and not paralyzed, we can see mandatory breath as a spontaneous breath. As breathing happens because of the coordination between patient as well as the ventilator, we should always understand how to get the spontaneous breath in ventilator, because our ultimate aim is the get the spontaneous breathing from the patient. So initiation is or triggering generally happens a time trigger, on spontaneous either flow trigger or pressure trigger. Limitation generally control, that is either pressure control or volume control. Cycling normally in mandatory breathing is time cycling. In spontaneous mode, it could be flow cycling or it could be time cycling also. In baseline pressure, we generally keep POE PEEP. Another important thing is that we have to understand some of the machine use the assist control ventilation. What do you mean by that? Whenever you do the continuous mandatory ventilation, 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 so we generally there are two types of breaths are there. One is called control breath, another is called assist control and assisted breath. What do you mean by control breath? Whenever machine initiates and machine completes the rest of the part of the breath, then it's called control breath. When patient initiates but machine completes the rest of the part of the breath, then it is called assisted breath. Both are mandatory breath, but one is initiated by the patient, one is initiated by patient, and another is initiated by the machine as per time trigger. We'll understand details about this thing, triggering. So here, in the pressure control ventilation curve, we can see there is some pink color that is marked with an arrow. This is indicate this is spontaneous mode when patient has initiated the breathing. And also there is a negative deflection on the pressure curve. Now the trigger The time trigger we have to understand as we prescribe the respiratory at 12. So we can see every 5 seconds, one single inspiration is starting. That's why it is called time trigger. Next, flow trigger. Whenever a patient is taking spontaneous breath, we allow the patient to take the breathing. So we keep a zone of deflection. So how does flow trigger happens? If you set a flow trigger at the level of 3 liter, so what will happen if there is a continuous flow is happening into the circuit? Suppose the continuous flow is 5 liter and patient has taken 3 liter breath. So the expiratory valve will sense this 2 liter flow. So automatically the ventilator will stop initiation of breathing and patient will initiate the breathing. That's called flow triggering. This is the commonly used triggering methods. Next is the pressure triggering. Whenever there is a circuit leak, there is a drop of pressure, patient can see that, and it will lead to pressure triggering. Another important thing is that flow triggering as well as cycling control. So here you can see whenever the pressure is reached at the level, whatever we have said, the flow is gas flow has completed, and the inspiration is completed by and it's cycled to the expression. Where if we set the inspiratory cycle off at 15%. So what do you mean by 15%? So if you set 20%, that means within the 100%, 80% inspiratory flow is completed. Then machine is telling that go for the expiration. That's called flow cycling. These are the things that are happening because of the time cycling. Here you can see one pressure support ventilation, where ventilation is going on in the pressure support ventilation. Now, the mode of ventilation we divide into two parts. One is called spontaneous mode of ventilation. Another part is called mandatory ventilations. In spontaneous ventilation, we generally use CPAP mode and CPAP plus pressure support. And we generally see how ventilator operates. We see that what is the control, what is the breath sequence, then what is the primary target. Next, we see what is the trigger, then what is the limitations, what is cycling, and what is support. In CPAP ventilation, patient continuously taking breath with some continuous ventilation taking with set point of pressure. What is the pressure? CPAP pressure. But there is no support, there is no initiation. All initiation is done by the patient. Here, in case of CPAP plus pressure support, this is also continuous spontaneous ventilation. But here, either patient is initiating by the flow or pressure trigger, and also cycling is happening by the flow trigger that we discussed in the previous slides. Next, we see the continuous mandatory ventilation that could be pressure controlled or that could be volume controlled. In pressure control, we can see the pressure and we can see the curve like this in the pressure wave, and the volume control we can see the pressure wave like this. You will also look for the flow curve in the next slides. Here the breath sequence is continuous mandatory ventilation. Here is also breath sequence the continuous mandatory ventilation. What is the set point? Here is the set point is the pressure. Set point is here is the volume when the fixed volume is achieved. What is the initiation of the breathing? Either time, flow, or pressure. Whenever patient is taking breathing, starting the initiation, the flow or pressure trigger. And the machine is triggering, that's called time trigger. Same for the volume control ventilation. So limitation we understand from there is a pressure and the volume. Cycling is here, both have the time trigger, time cycling. There is no pressure support. So there is no spontaneous ventilation in case of continuous mandatory ventilation. Whereas in SIMV, pressure control plus pressure support mode, here patient can take some spontaneous breath, whether could be supported or it might not be supported. These are the machine breath, these are the pressure supported, or these are the spontaneous CPAP pressure breathing. Next, we can see the different types of mode of ventilation. This is volume control ventilation. Start the video. We can see this is called constant flow. There is a flow, pause of flow, then expression has started. This is a volume control mode of ventilation. From the flow curve, we can identify this is a volume control mode of ventilation. From the pressure control ventilation, we can see there is a decelerating flow followed by flow pause, and again the decelerating flow in the expiration is happening. So this is pressure control ventilation. See another picture of video of pressure control ventilation. And also we can see there is a loops are there, volume pressure loop in the pressure support and CPAP ventilation, where the patient is initiating the ventilation after a certain time, and we can see the loops. Now, two maneuvers are commonly used for mechanical ventilation. One is called plateau pressure. What is plateau pressure? Plateau pressure is the pressure which is generated within the alveoli when there is a no flow inside the lung. So this is normally in the volume curve. We can see it's done in the volume control ventilation. There is no flow zone. This pressure from here to here, this pressure is called, this is the blue one. Sorry, the sky one is the plateau pressure, and there is a no flow zone. In pressure control ventilation, normally we consider PIP as a P plate or peak inspiratory pressure as a P plate. But if the inspiratory flow is not completed, in that case, we do not see as a PIP is equal to P plate. Let's see in volume control ventilation, how do we do the inspiratory? How do you get the plateau pressure? In volume control ventilation, we see the plateau pressure by inspiratory hold. Can see the video that inspiratory hold is happening and the P plateau pressure is changing. Next important maneuver is the how to get the auto PEEP. What is the auto PEEP? Normally in ventilator, particularly obstructive airway disease, there is a definite generation of some PEEP is generated that is called increasing to the lungs rather than the PEEP what is given by the ventilator. And that leads to hyperventilation. We can see from the flow curve that the expression is not completed. That's the incomplete expression called auto PEEP. And as there is PIP minus PEEP is gradually reducing, gradually there is generation of flow stagnation is happening inside the lung, leading to inflation. That also can be measured by the expiratory hold. In the expiratory hold, we can see that this is the PEEP external and this is the PEEP internal. Let's see the video. Whenever you hold the expiratory pause, on the ventilator, we can see there is a change of PWP PEEP. There is a normal lung, it's not changing much. So, but how will you do that? That we can see from this video. Now there are different loops that called pressure volume loops. From this pressure volume loops, we can identify so many things. Suppose the compliance is decreasing. This is the volume pressure volume loop, and this is the pressure volume loop in pressure control ventilation. In volume control ventilation, as the volume is fixed, as the compliance is decreasing, so we need to increase the pressure. In case of pressure control ventilation, as the compliance is decreasing, so volume is gradually decreasing. Same time, we can identify whenever the airway resistance is there. Also, we can find out the airway leak. Another loop is the flow volume loop. That also indicates there is a restriction of the flow or compliance is low. As restriction of the flow, there is a air stagnating or gas trapping is happening. Also, you can see there is a obstructive airway disease pattern, and secretions also could be seen from the flow volume loop. Ventilation purpose, most important by oxygenation and ventilation. Oxygenation depends on the mean airway pressure as well as the FiO2. Mean airway pressure is increasing the PEEP, increase the PIP, increasing the inspiratory time, and increasing the inspiratory flow. That increases the volume, and increasing the rate more or inverse ratio ventilation also increases the oxygenation. Whereas ventilation is the nothing but the minute ventilation, which depends on the tidal volume, expiratory tidal volume, as well as the frequency or respiratory rate. So if you increase respiratory rate or increase the tidal volume, CO2 will be washed out from the ventilation. Now, next important thing is that ventilation is two-way process within the patient as well as the ventilator. So basically, there are a lot of asynchrony could happen. Suppose these modes of mechanical ventilation, we do the volume assist control, pressure control, and whatever that. If we see in volume assist control, we set 3 parameters: time, flow, and volume. With pressure assist control, we control pressure and time. And pressure support, we control the only pressure. But new ventilation, that is called proportional assisted ventilation and NAVA, we don't set any parameter. So whenever we control more, we are seeing the asynchrony more. And so in volume assist control, the maximum asynchrony happens. There are various asynchrony. at the initiation, at the limit, as well as the completion. So they're called trigger asynchrony, flow asynchrony. We need detailed discussion about that in the next class. Now we have to understand the weaning of extubation of patients. Weaning, or we have to extubate the patients. How do we extubate the patients? There are various criteria, but most important thing to understand, resolution of disease is the most important other than other parameters. The purpose for which we intubate the patient, that should be resoluted. And whenever there is a failure, we have to understand that whether we are not able to support or the disease process has not completed and other parameters are hindering to extubate the child. We have to understand. So basically during intubation, what are the things you have to understand? First, mechanical ventilation, then gradually weaning, then extubation. 24-hour extubation, we have to understand whether the weaning failure is happening or not. Now, in European, there is a consensus guideline for how to mechanically ventilate the patients. So basically, they say whenever disease trajectory is getting worse, we should go for more invasive, even up to the high frequency oscillatory ventilation as well as the ECMO. When the disease trajectory is getting better, we gradually come down from ventilation, wean the ventilation, and ultimately do the extubation on NIV or spontaneous mode of ventilation. So from graphically, we can present this thing. You can see that as per the disease, the restricted disease is the obstructive airway disease as well as the mixed disease. In all the conditions, we can see whenever the disease severity is increasing, we are increasing our support from high frequency oscillatory ventilation, extracorporeal life support, neuromuscular blocking agent. But important thing to understand, whenever the lungs is condition is poor, we always reduce the tidal volume at 5 to 7 ml per kilo. That is called lung protective ventilation, as well as we reduce the P flat below 28. And whenever the disease severity increases, we also monitor more invasively to the patients. Last not the least, we always understand why we are ventilating. So the important thing is that ventilation is the only purpose to keep the patient alive, while something good can happen to allow them to breathe for themselves. So ventilation is nothing but the transitional support. If the disease is not improving, there is no value of mechanical ventilation. Ventilation might not cure the patients, but it can damage the lung. Oxygenation generally happens because of the adequate alveolar and capillary gas. So we have to understand the cardiopulmonary physiology to get the better oxygenation. Only ventilation doesn't going to help oxygenation. Carbon dioxide is removed by establishing adequate minute ventilation as well as the perfusion. Thank you very much.